Welcome to the Cure Sickle Cell Initiative's Get to Know Gene Therapies webinar. My name is Traci Mondoro. I'm the Associate Director of the Blood Division at NHLBI and the Program Director for the NHLBI Cure Sickle Cell Initiative. The Cure Sickle Cell Initiative, or CureSCi, is a program of the National Heart, Lung, and Blood Institute, which is part of the National Institutes of Health. CureSCi is a collaborative, patient-focused research effort designed to accelerate promising gene therapies for sickle cell disease. As you may know, in December of 2023, the U.S. Food and Drug Administration approved 2 new gene therapies to treat sickle cell disease. We've heard from the sickle cell community that there is a need for more information about gene therapies, and we are hopeful that this webinar will help participants better understand gene therapies, the importance of being prepared for the procedure if they choose to participate, and some of the mental health considerations as it relates to curative therapies. Today's session will be a moderated panel discussion with experts in the field that can share important perspectives, including a researcher, a clinician, and an individual living with sickle cell disease. I will now turn it over to Dr. Julie Panepinto, who will lead the discussion.
Thank you, Dr. Mondoro, and hello to everyone and welcome. I'm the Director of the Blood Division of the Heart, Lung, and Blood Institute at the NIH. It's a pleasure to be here and to have the opportunity to moderate this webinar. We're going to begin with each panelist briefly introducing themselves, and then we'll follow that with a roundtable discussion that focuses on getting to know gene therapy. We have an exciting group of panelists who each bring a different perspective of to this topic. So let's begin with our introductions. Dr. Tisdale.
Hello, I'm Dr. John Tisdale, and I work in the intramural program of the National Heart, Lung, and Blood Institute. And I've been here for about 30 years working to develop gene therapy for sickle cell disease.
Thank you. Ms. Drew.
Hi, I'm Clevetta Drew. I am a participant and patient at NHLBI as a gene therapy trial recipient.
Welcome. Thank you. And Dr. Hardy.
Hello, I'm a pediatric psychologist at Children's National Hospital in Washington, D.C. I have been involved for the last several years through the Cure Sickle Cell Initiative's Patient Readiness and Resilience Working Group, and I'm excited to be here today.
Great, thank you. So Dr. Tisdale, we're going to start with a series of questions for you, with the first being, can you spend a few minutes describing first what is gene therapy for sickle cell disease and what types of gene therapy are used to treat sickle cell?
So gene therapy is a broad term used to describe efforts to take a genetic manipulation and make it therapeutic. And so in the case of sickle cell disease, that's long been divided into sort of 2 types. One that you hear mostly described as gene therapy, we call gene addition. So in that case, we're adding a gene to a patient's bone marrow cells that can make a protein that will fix the disease. For the most part, that means adding the gene for beta globin, which is the gene that's misspelled in sickle cell disease, and giving those cells back. We also have what we call gene editing, which is where we use some newer technology that allows us to cut and sometimes even mend DNA. And the most prominent way of doing that at the moment is using this technology to cut a gene that suppresses fetal hemoglobin. So in this case, we go back to making the kind of hemoglobin that we made in utero, which can substitute for the sickle hemoglobin. And so both of these approaches, gene addition and gene editing, can make red cells with a protein that no longer produces sickling and therefore can fix the disease.
Thank you. So understanding that those 2 methods or processes of doing this, can you spend a little bit of time talking about what really happens during the process of gene therapy and how long does it take from start to finish?
Yeah, so the first thing to mention that's really important is that this is in fact a transplant. I talk to many patients who come and want to hear about gene therapy. So I start describing transplant. They say, no, I don't want a transplant. I want gene therapy. So gene therapy is a type of transplant. And we know we can cure the disease with a bone marrow transplant. We've known that for decades now using a brother or sister that's a tissue match. But in this case, we're taking the patient's own bone marrow cells and transplanting them. But because we know so much about doing transplants, we can take the cells out of a patient. We can sift through those cells and find the seeds that grow blood. We call those stem cells. And then we can use those cells to either add a copy of the gene addition strategy, or to edit a gene, the gene editing strategy, basically in a flask, in an incubator outside of the body. And then once that process is done, we can freeze those cells down. We can keep them for a long time. We can make sure that we got the high efficiency that we know we need to fix the disease. And then if we did, we can bring the patient back and do the transplant with their own cells. So, what that really means is that a patient has to come in, donate their own cells. We do that with a process called apheresis, which is, collecting those stem cells from the blood on a machine for 3 or 4 hours. That process often has to be repeated, not one time, but sometimes 2 or 3 times to get enough cells to do this manipulation. And then while this manipulation is going on, the patient, can resume their normal activities. But then once those cells have been modified and everything is known to be done, to the highest efficiency, we can bring them back for the transplant. That means they have to come into the hospital, get chemotherapy to knock out their remaining bone marrow cells, get those new cells infused. It just goes in through an IV. It finds its way into the bone marrow and starts making blood. But that process takes a few weeks for the blood forming cells to start repopulating all of the blood elements. That means the patient has to get antibiotics, probably because their white blood cells that fight infection are down for a while. They'll have to get red blood cells because the red blood cell forming ability is also knocked out by that chemotherapy. And finally, they have to get platelets. Those are the blood clotting cells, because those too are knocked out for a bit. So that process itself takes about a month from start to finish. It can be longer if cells are slow to come in. It can be faster if the cells are faster to come in. But on average, that process takes about a month until the patient's making their own blood without infections, has a normal white count again, and platelets that are high enough to prevent bleeding.
So you mentioned efficiency. Can you explain a little bit more about what you mean about the efficiency of the cell collection, or the, I think you talked a little bit on that. What does that mean to an individual who undergoing this therapy?
So when we're collecting cells, we have in mind a number of those bone marrow seeds that we want to get. We want, a lot, because we know we need a lot to do a transplant. It's over 5 million of those particular type of cells per kilogram of the patient's body weight. So we have to collect a lot of them. So that means we sometimes have to do more than one cycle of collection. And for the most part, we can get that. It's rare, but it does happen that we are not able to collect enough cells. And then when those cells go through the process, we have to be able to, as I said, sift out the seeds of the bone marrow from the rest. That process itself can have varying degrees of efficiency. And then we have to either put the gene in the case of gene addition, or we have to cut the gene in the case of gene editing. And we also want that process to be high, because we want the cells that we give back to be mostly fixed. More than half of them need to be fixed in order for the disease to go away. So we want that process to be also of high efficiency. And we spent, a lot of years trying to make sure that we could get all of those efficiencies high enough to make this work, to to combat this disease.
So then if you were an individual undergoing this therapy, what are some of the risks and benefits that the individual may have to think about?
So the biggest ones are the ones that come from getting what we call an autologous bone marrow transplant, meaning you're getting your own bone marrow cells back as a transplant. And they mostly relate to the chemotherapy that we give, busulfan. So it's a very good drug to knock out all of the remaining cells so that all the cells that we give make blood and aren't competed by the ones that got left behind. So this drug in the short term causes hair loss, mouth ulcers, drops all of the counts, so you have to get transfusions, drops the white blood cell count, so there's risks of infections. Those are normally controlled by those white cells, so when they're away, mischief can happen. And, we know the types of infections that patients get when their white count is knocked down, but, sometimes that can be a bad infection. With the platelets being low, there's the risk of bleeding. And in particular, in sickle cell disease, in the early days of transplantation, there was the risk of bleeding in the brain. And so for that reason, we have a much higher threshold for starting platelet transfusions. But these are some of the short-term risks. There's also the risk of precipitating a pain crisis when you come into the hospital for collection of those cells. So some patients will end up having to stay in, even though we got enough stem cells. They may have to stay in and get pain medicines for a few days beyond the anticipated discharge date. And sometimes, when you come in the hospital and you have all of this done to you, chemotherapy and infections and what have you, can have pain events around the time of the transplant. So those are the major risks.
Last question for you. As Dr. Mondoro mentioned in the opening, the FDA has already approved 2 gene therapies for treatment in sickle cell disease. So why are there still other clinical trials occurring?
Well, so I think first and foremost, we need competition. These are very expensive strategies. So the more that come out, I think the better able we are to manage cost. Second is that, as I mentioned, efficiency. So as we get better at editing the genome, for example, we have better strategies for either reactivating fetal hemoglobin, which is the current one that's approved with CRISPR, but we have other ways that we can actually change the spelling of the sickle hemoglobin back to the normal adult hemoglobin, which would be even better. It's certainly more elegant to do it that way, and I think it will be better in the long run for patients. So there's still much to do, and there's also the need to develop ways of getting these cells in that aren't so toxic. So some of these strategies are incorporating ways to make the patient ready for these new cells without having to get this chemotherapy busulfan. And then finally, there's a lot of work ongoing now about trying to figure out how to do this in the patient instead of in the flask. Can we take these tools that we developed and then just inject the tools instead of taking the cells out and putting them together in a flask?
Well, thank you, Dr. Tisdale, for all that information. We're going to move to Ms. Drew now for some questions. So, Ms. Drew, what does an individual need to know or understand before participating in a curative therapy trial?
First thing I would say is it's a process. There is no preparation for understanding that there's a screening process where you have to become eligible in order to participate. And then there are stages. So Dr. Tisdale mentioned the apheresis. There were lots of appointments. There is, depending on where you live, travel to and from the facility. The appointments can include imaging, MRIs, CT scans, blood work, and they can vary from appointment to appointment, sometimes including overnight stays, and even up to a week or more. So in between your transplant process, you're also managing yourself at home and whatever you have going on in your personal life. So it is definitely a mental thing. So that's the second thing I think you have to prepare yourself for, is understanding that you have to just be ready to undergo lots of additional appointments outside of what you normally do in your day-to-day life at home.
So given all of that, can you walk us through what ultimately led to your decision to participate in the clinical trial and undergo gene therapy?
Yes, a little backstory, I didn't really have crises during childhood. They came more so in adulthood. So after the age of 19, when you're starting to work and, be out in the world on your own, and it became more and more difficult to manage, and it really affected my quality of life. I experienced job loss, prolonged time finishing for continued education, and altered my day-to-day life to the point where I didn't really feel like I had a normal life anymore or anything close to it. So my quality of life just diminished. I was depressed. I wasn't getting out of bed for weeks at a time sometimes, as well as going to many ER, the urgent care facilities and hospitalizations. And so, I kind of weighed what my life looked like. I also started going to NIH around 2011 and participated in some other trials for treatment. And the treatment worked for a time, and I saw a decline in my health after a few years again. So based on, just watching this continuous decline in my life, I decided to go ahead and look into options for transplant.
Thank you for sharing that with us. And you mentioned your mood and having trouble getting out of bed. Were you able to address any mental health issues around the curative therapy? And if so, how did you specifically address them?
Yes, during the transplant process, I participated in a lot of alternative therapy at the clinical center, including guided imagery, mindfulness meditation, as well as psychotherapy. There were therapy dogs there. There was art therapy there, and lots of different treatments that I hadn't opened myself to before that time. The psychotherapy was particularly helpful because you don't know. Sometimes when you have a disease, you don't think you need it when you're doing okay. And I was walked into that process of, you could still use some help, even though you're in a better state, even though you're going through something that's ultimately going to change your life. It's helpful because your homeostasis is changing. The base and your foundation is going to be different afterwards. So while all the appointments and everything gave me something to do to get out of bed, it was still good for my mental health to look at things a little differently and think about how I was going to move forward post-transplant.
So thank you, and that's it sounds like having those resources available were quite helpful for you during that time. So what advice would you give someone else who may be considering curative therapy?
Lots of advice. First of all, it is a little bit of a stigma to quote unquote be a guinea pig, but it's a personal decision. You have to make a strong decision and stick with that because it takes a lot of mental toughness, even when you're going through something physical with your body, to withstand this process. So over everything, they kind of all tie in that the appointments are a process, that you have to manage your mental state. Sickle cell is not just a physical disease. It's also a mental component there. And putting that at the forefront with your decision-making, asking for support, and allowing your support system to also be outside of your family members, but to learn to rely on the team that's provided for you is also helpful.
Great, thank you for sharing that. And I think you emphasize the physical health and the mental health, and the really how all of that came together and really was a big part of your decision, it sounds like. So thank you, Ms. Drew. I think nice segue for our next panelist, Dr. Hardy. Dr. Hardy, how does a person living with sickle cell disease know if they're ready for curative therapy, and what things do you recommend they think about or consider?
Yeah, thank you. I think, as I think about readiness and how someone might know if they're ready or not, it's probably important to point out that I don't know that anybody really knows, whenever they're definitively ready. I think readiness is probably something that exists on a continuum. Some days you may feel more ready than others, and that I think you can probably expect to change a little bit over the course of your journey, considering something like gene therapy. But I think some of the things that Ms. Drew spoke about are so important. So doing some reflecting on your current satisfaction with your life and the ways that sickle cell disease may disrupt your ability to participate in activities, doing some reflecting on your values and the goals that you have for yourself, and the degree to which gene therapy may affect your ability to pursue some of those dreams that you have for yourself. But I think also a big part of moving towards being more prepared and more ready for gene therapy involves just seeking out information from trusted sources, being patient, understanding that this can be and should be a long process, and not just a quick decision or a single discussion, but it should involve many discussions. And you should look for opportunities to get all of your questions answered. If you find it helpful, having family members or other advocates attend those education meetings with you to make sure that all of your questions are answered. I think it's also making sure that you feel confident in terms of your understanding of the pros and cons of the treatment, the things that could go right and how that could affect you, the things that may not go right, and what that might mean for you and how you would cope with those situations should they arise, and sort of feeling as though you sort of have a plan for what's going to happen before treatment, during treatment, and then after treatment, in a variety of scenarios.
Great, so thanks for outlining that what sounds like pretty complex preparation, but really important. And so along those lines, what's from your perspective, the best practice to assess readiness for gene therapy? Are there tools that providers can use?
Yeah, absolutely. So our patient readiness and resilience working group through the Cure Sickle Cell Initiative spent a couple of years working on recommendations for how to assess patient readiness and develop some areas that we recommend monitoring and assessing and having conversations about with patients. I think it's important to highlight too that a part of our working group, it was psychologists, but also we had patients who are a part of that group and caregivers who I think really meaningfully enhanced the value of the work that we did. This guidance is actually publicly available. It's on the Cure Sickle Cell Initiative's website. It's also recently published in JAMA Network Open. So it's out there for everybody to access. And, I think the areas that we think about in terms of being the most important best practices for assessing readiness really involve ensuring first that education is being effectively delivered, that it's done carefully and deliberately over several months and several visits. It's taking time to really get to know your patients and understand the things that are important to them and the worries that they have, the concerns they have, and making sure that those are addressed. And then a big part of what we recommend as well is really thinking through the potential risk factors and not just from physical health standpoint, but also what are the mental health concerns that you need to be aware of and do things to support patients while they're in treatment and well beyond treatment even. And at the same time, part of readiness, and thinking about getting ready for something like gene therapy is also thinking through what are the strengths that the patient has? What are the things that we can really lean into and activate in terms of their social support networks and their coping skills and things like that to ensure that we're helping people get through the treatment as well as possible and be healthy and successful long term.
So you mentioned the resources that were available to the public on resilience. Are there, if you're an individual living with sickle cell disease, are there any resources you might direct them to for them to assess their own readiness?
Yeah, that's a great question. So, unfortunately, we don't have sort of like a checklist or a guide at this point to where somebody could go and sort of try to figure out what their level of readiness is. But what I would encourage people to do is to go and look for the white paper that is on the website. And it's no secret. It's not something that only certain people should have access to. I think these are questions that we would encourage providers to be asking patients, but patients certainly should feel comfortable going and looking at that document, where we actually do outline example questions that providers may ask. And so I think, it would be a good idea for patients to take a look at that themselves and ask themselves those questions and sort of see where they are at that point in time, recognizing that this is something, again, that readiness is something that can fluctuate and change over time, but maybe looking through those questions would give them new ideas about questions to ask their providers whenever they go in, or think through different supports and coping strategies that they may not have considered before.
Thank you, Dr. Hirsch. So how can providers and researchers better understand this spectrum that's involved in gene therapy? And maybe I'm getting at what a cure might mean, as it might mean something different to everyone. And in addition, the benefits and risks might mean something different to individuals. So how can we help promote better understanding of all those different perspectives?
Yeah, I'm glad you brought that up because I do think that's an important point is really understanding for each individual what gene therapy means to them. And whether that is thinking through, the degree to which this may be considered a cure or thinking through what receiving gene therapy may mean in terms of their own personal identity as a sickle cell warrior. And so I think those are really important and delicate conversations to have with each individual patient, recognizing that, the definitions that people use may be different. Everybody is coming to the table with really unique and important experiences that maybe will be really impactful in terms of their long-term coping. But I do think, especially as we're thinking about, the early stages of gene therapy really being available commercially, it's sort of recognizing that a lot of patients, may be receiving the treatment from providers that don't really know them very well. And so, an important part of this is really taking the time to get to know the patients and for the patients to get to know their providers and develop trust so that they feel really comfortable sharing, these perspectives, these worries, and recognizing that, again, that there may not be sort of like a perfect finish line that you cross where you feel like now I'm ready, but that that's something that probably develops over time, once you develop that trusting relationship.
Thank you, Dr. Hardy. So I want to circle back with one or two more questions for each of you that our external community has asked us. And I'll start, Dr. Tisdale, back with you. So is there an age range to be able to get gene therapy?
It's 12 and up currently. There are certainly efforts to lower that, but at the moment it's 12 and up.
And are all individuals outside of that age range, are all individuals with sickle cell eligible otherwise to receive gene therapy?
Well, I mean, to do something like gene therapy, the disease needs to be severe enough to justify the risks of a transplant. So they've mostly been studied in patients who have severe disease, and that defining severe disease was mostly frequent pain crises. So the typical patient who's eligible is someone who's in the hospital at least a couple of times a year for treatment of pain with IV medication.
Great. So Ms. Drew, I know we heard a little bit about your life in bits and pieces before the treatment, but if you could touch on a bit more what your life was like before your treatment with gene therapy and now after.
So growing up, as I said, I didn't have any pain crisis, but there were things like recurring pneumonias, infections, things of that nature. And then when the crisis began, it was 1 or 2 a year, as Dr. Tisdale mentioned, for hospitalization. And right before transplant, I remember one year I was in the ER about 15 or 20 times, which is extremely significant. Since transplant, I have had next month will be 5 years, and I have been in the hospital twice because I had a PE and the other was surgery. So I've only been to urgent care for a cold or something of that nature. It was completely outside of a pain crisis every time. Very different experience being in the ER with no pain medicine, no IV, and the doctor just doing a regular assessment. So it's significantly changed my life.
Congratulations on your 5 years, and wonderful to see the impact that gene therapy can have on an individual who, as you described, was living with quite severe sickle cell disease before the therapy. So thank you, Ms. Drew. So Dr. Hardy, who can people talk to for more information about gene therapy?
Yeah, well, I mean, general questions about gene therapy, I would encourage them to talk to their hematologist or transplant doctor or whoever at their hospital may be, involved in those trials. But in terms of any like questions about readiness or mental health, my hope is that everybody has access at their institution to somebody, who is tuned into the mental health and well-being of the patients. So that could be a psychologist, it could be a social worker or a counselor. I know Ms. Drew mentioned some of the other therapists as well that she had worked with, and so I think there's a variety of people that you could reach out to, and I think my hope is also that the concerns around mental health and psychosocial readiness is really something that is seen as a team effort, and so really anybody on your treating team should be open to talking to you and having those conversations and answering any questions that you might have.
Thank you. So thanks everyone for an engaging and informative discussion on a very relevant and timely topic of gene therapy and sickle cell disease. So before we end, I'd like to give each of you an opportunity to share one last thing, and that is what you think is the most important thing people need to know about gene therapy. Dr. Tisdale.
Well, for me, it's that gene therapy works, that it can reverse the course of this disease, stop it in its tracks. So it's really important to know that this type of therapy, gene therapy, to the patient looks just like a standard bone marrow transplant from a brother or sister. So that's really the most important thing from my perspective. We finally have gene therapy working.
Oh, that finally, yes. All right, Ms. Drew.
I believe sickle cell patients should know that even though it's a scary thing, and it may be something that is or was unknown to the community, it is definitely a possibility for it to be a cure for you. It is a curative treatment. It works for most of us. And I was in a place where I was trying to get my life back because I did experience having a pretty normal life. I know there are some who have never had a quote unquote normal life, and they are looking to gain that. And I encourage you to do the research, to pray about it, and trust your decision.
Great advice, and thank you for sharing your story to help others who are thinking about this journey. Dr. Hardy.
Yeah, I really am excited about the potential that gene therapy may have on also improving mental health and some of the psychosocial concerns that people may experience related to sickle cell disease. I think we're still learning, but I think there's good reason to think that in many ways your quality of life may improve after gene therapy. But I really think that Ms. Drew gave us great advice where she just said, ask for help. There are resources available to you, and if there are concerns that you have related to gene therapy, and how to navigate the process, and then think about reintegrating into your new life after gene therapy, that there are people out there who have the expertise and are willing to help, and would just encourage you to say something if you need support.
Thank you. So I really appreciate everyone spending time with us today and sharing your expertise. I will now turn it back over to Dr. Mondoro.
As we wrap up the webinar, we want to thank our panelists and the sickle cell community for joining us today. If you haven't already, we encourage you to sign up on our website to receive updates by visiting curesickle.org and follow us on X at the CureSCi. Thanks for joining.